Hi, this is Professor Nicholson lecturing on applying the nursing process to patients with elimination needs. This lecture is specific to Unit 7, Module 4, Bowel Elimination Needs. Please review the sub-competencies on your own. Please keep in mind appropriate terms to use regarding bowel elimination. Factors affecting bowel elimination. Regarding developmental stages, infants have a rapid peristalsis that leads to frequent bowel movements. Their neuromuscular development allows them this control at around 2 to 3 years old. Older adults lose muscle tone and peristalsis decreases. Comorbidities may also affect bowel elimination patterns. Pregnancy slows peristalsis, and fetal obstruction, as that fetus gets bigger throughout pregnancy, may obstruct the flow of the bowels through the intestines. Nutrition and hydration. You need to educate your patients to have adequate fiber and fluid intake to aid with proper bowel elimination. And of course, activity. Increased activity increases peristalsis. More factors affecting bowel elimination, so cultural factors, such as keeping in mind some patients prefer the squatting position for bowel elimination. So ask your patient, how do you usually have a bowel movement when you are at home? Personal habits or factors. The patient may ignore the urge to defecate. They may need privacy or even avoid public restrooms due to the noise or even the smell. Other factors could include that a patient may be having a difficulty time with using bedpans and commodes. So educate your patient how to use these and again, provide them some privacy. Medications could be a factor. Antibiotics could cause diarrhea. Narcotics could cause constipation. You need to know that. Narcotics can cause constipation. And also know some meds cause color change, such as some anesthetics. And then abdominal surgery. This slows peristalsis and reduces patient mobility. Surgery requires narcotics, which again can cause constipation. And then also pain. Maybe the patient is experiencing hemorrhoids and it's too painful to pass a bowel. Promoting regular defecation. Provide privacy to your patients. Make sure they're in the correct position, so seated upright with knees higher than the hips. When do they defecate? This often occurs after meals or hot liquids. Some patients may need assistance, so please answer those call bells promptly. And don't forget hand hygiene for your patients. You want to encourage fluids, so make sure your patient has 8 to 10 glasses a day, has a diet high in fiber, such as fresh fruits, vegetables, whole grains, and legumes. Exercise. Make sure you educate your patients to exercise 3 to 5 times a week. Make sure they have a good range of motion and turn patients that are on bed rest. And again, ambulation. Movement increases peristalsis. Checkpoint. A patient with a hip fracture is having difficulty defecating into a bedpan while lying in bed. Which nursing action would assist the patient in having a successful bowel movement? The answer here is raise the head of the bed. This would give the patient a more natural position to allow proper muscle contraction for elimination. What is normal? There's a wide variation of how frequent somebody passes bowels. It could be 3 times daily to 1 to 2 times a week. There's a daily bowel movement myth where everybody needs to go daily, but this may not be the case with some patients. But the key is a regular pattern and to ensure that bowels are formed and brown. You do not need to memorize this chart, but you should know the progression of stools. Stool color can be affected by food and medications. There's a possible pathology, so black stool could mean old blood and the fact that the patient's taking iron supplements. You need to know that. Red or red streaks, this could be fresh blood. Yellow stool, this could be fatty, so malabsorption. And then clay colored could mean biliary obstruction. The following slides are common conditions affecting bowel elimination. Constipation. Signs and symptoms include small, hard stools that are difficult to pass, the inability to defecate despite the urge, abdominal cramping and/or abdominal distension, as well as straining. Keep in mind, straining can cause wound dehiscence, syncope, hemorrhoids, heart attack, as well as ruptured blood vessels. Again, as you go through these slides and you hear words that you are not familiar with, please take a moment and look these up on your own. You need to know risk factors for constipation. Again, elderly, pregnant, as well as patients who have just undergone abdominal surgery have a slowed peristalsis, placing them at risk for constipation. Medications such as opiates, antidepressants, painkillers, certain antacids and iron supplements, anticonvulsants, and antispasmodics, as well as Parkinson's disease drugs and calcium channel blockers. These can cause constipation. You need to know that patients need adequate intake of dietary fiber. They may not have adequate amounts, as this could be associated with a low income, fast food consumption, or even GI pathology, such as irritable bowel syndrome. And don't forget, beans is a great source of fiber. Regarding fluid intake, slowed peristalsis means there's more reabsorbed fluid from stool, hence the constipation. This is why patients need sufficient I's and O's. These should pretty much balance out. Again, lack of physical activity can slow peristalsis. Managing constipation. Prevention. Please go back to the slide on how to promote regular defecation for review. And again, help patients to a position that helps facilitate defecation, as appropriate to their condition, of course. Provide them privacy, allow uninterrupted time, increase their intake of high fiber foods, increase fluid intake, increase activity and exercise. Stool softeners may be used in conditions commonly associated with constipation, such as iron supplements, patients taking prescribed narcotics, post-op scenarios, as well as pregnancy. Laxatives are only used when lifestyle changes are ineffective. Fecal impaction is the inability to expel feces in the rectum. This can lead to a bowel obstruction. Stool becomes very hard and dry. Signs and symptoms include inability to defecate or for an extended period of time, oozing of diarrhea around the impacted stool, abdominal or back pain and distension, nausea and vomiting, as well as tachycardia, dizziness, hypotension, and diaphoresis. Again, if you are unfamiliar with a term, please take a moment and review. Managing fecal impaction. Prevention is the best treatment. Diagnosis is by digital exam as well as X-ray. Enemas. You need to know that these moisten and soften the stool so it can be removed or passed out of the body. Oil retention is used to soften. Tap water or fleet enemas are used to remove and cleanse. Disimpaction is a gentle digital removal. So disimpaction is separate from enemas. Diarrhea. This is a frequent passage of unformed feces. This results from fast movement through the colon, which does not allow for fluid reabsorption. This is caused by food intolerances, antibiotics and other medications, pathogens, such as ones from infections, food contamination and travel, as well as inflammatory conditions. Dangers of diarrhea. This includes dehydration. Infants and elderly are at especially high risk. Electrolyte imbalances could occur as well as skin excoriation. Managing diarrhea. You need to know this. Diet includes clear liquids. Water does not contain any electrolytes. So what's better? Juice, broth, as well as coconut water. A replenishment drink is what the patient needs. You need electrolytes. A brat diet is a low residue diet. However, long-term brat is not recommended. A brat diet includes bananas, white rice, applesauce, as well as white toast. You want to make sure a patient experiencing diarrhea avoids fatty, spicy, dairy, and high fiber foods. Managing diarrhea further. IV fluids should be used if the patient is dehydrated or there's an electrolyte imbalance. Antidiarrheal medications may be needed. Probiotics, these contain strains of living bacteria that are similar to the healthy bacteria normally found in your digestive system. They may boost the number of healthy bacteria present to fight germs in the digestive tract. Skin care. Keep skin dry. Clean it. Use pH balance cleansers. No rinse cleansers should be avoided because you don't want to cause skin damage. You want to protect the barrier with creams. Fecal incontinence. This is the loss of bowel control. This ranges from leakage of stool to complete loss of control, and it may be intermittent or chronic. This is different from impaction. There's no nausea, there's no distension, and there's no pain. The actual prevalence is unknown, and it's underreported, especially among younger adults. It's similar to urinary incontinence, but less easily hidden in public, of course. Causes include inflammatory bowel disease, anal sphincter or pelvic floor damage, infections, so anything that causes diarrhea. Neuro causes include dementia, MS, as well as paralysis. Functional causes, not related to the GI system, but these include communication, mobility, and cognition factors. And a few other causes include hemorrhoidectomy, childbirth, as well as radiation. Consequences of fecal incontinence. These are similar to urinary incontinence. So skin breakdown, the stigma, the social isolation, the low self-esteem, and this also increases the risk of UTI. Interventions of fecal incontinence includes addressing the underlying cause if possible. Also, skin care to prevent breakdown. This includes immediate cleansing of the skin to protect that barrier, as well as barrier creams. You want to educate your patients as well. So maybe educate them on continence products if this is the route they need to take, such as utilizing an indwelling bowel catheter system if ordered. And this may or may not be needed. It is similar to an indwelling catheter, however, it's for short-term use, so less than 1 month. And this is especially used for patients bedridden and unable to use the bedpan. Also, education on habit training, assess their pattern, how usual they do toilet, so do they usually go after meals, as well as assessing how well a patient is able to utilize their gastrocolic reflex. This is when the colon has increased motility in response to the stretch of the stomach with the ingestion of food, such as after a large meal with healthy fat. And then, of course, ensuring your patients avoid any stimulants. A bowel diversion is a temporary or permanent stoma. So this is an opening in the abdominal wall. If there's a stoma at the ileum, this is called an ileostomy. And if there's a stoma from the colon, it's called a colostomy. People have bowel diversions for reasons such as cancer, inflammatory bowel disease, obstruction, as well as abdominal wounds. The location of the stoma is what determines the stool consistency, such as most watery stool occurring earlier in the intestinal pathway. The stoma drains into a bag, which is attached by an adhesive appliance. Managing a bowel diversion includes stoma assessment and care, proper fitting appliance, strict attention to skin care and peristomal skin assessments, and monitoring the amount and type of effluent. You want to be attentive to the patient's psychosocial needs, such as be professional, show acceptance, attend to odor control, and address patient participation in ostomy care. Patient teaching for home care is also included in this. Stool specimens. Know that stool is not sterile and that E. coli bacteria is present and mostly harmless within stool. Stool specimens must not be contaminated with urine or water, and you need to know the collection technique, and that containers vary by specific test, such as knowing the amount to collect as well as if it needs to be refrigerated or not. You should follow the facility's protocols. Also, understand that analysis of specimens includes cultures for pathogens, such as C. diff, as well as guac testing, which will be discussed next. A stool analysis for blood includes a fecal occult blood screen, so a guac screen. You need to know occult means microscopic, so not visible to the naked eye. This is for screening. It's not a diagnosis. You need 3 recurrent positive results, and then further evaluation needs to be completed. This can be done at the bedside, home, or in the lab. It's a thin smear on a special card, followed by drops from a developer. False positives can occur, and this is typically from food or medications, such as red meats, NSAIDs, and iron. You should also know that there are different types of tests, such as an immunochemical lab test that uses antibodies to detect blood. This is a sample of a guac testing. So on the left side, that's negative, and on the right side, that's positive. The nursing process includes obtaining a patient history, utilizing therapeutic communication, because remember, this can be a sensitive topic for patients, be neutral with them, and matter of fact, such as saying, many people have problems with such and such. Again, sensitivity to a patient's cultural and psychosocial factors is important. Know their usual patterns of their bowel movements. Note any changes, as well as any concerns or impact on their life as well as relationships. And again, utilize that Bristol stool chart as previously described. Nursing process continued. When assessing the abdomen, you need to inspect, auscultate, then palpate and percuss. You never place your hands on the abdomen prior to inspecting and auscultating, as this can alter sounds. You need to auscultate bowel sounds in all 4 quadrants up to 5 minutes or until bowel sounds are heard. Absent bowel sounds are 0 and 5 minutes. Hypoactive are 1 to 5 per minute. Normal are 5 to 35 bowel sounds in a minute, and hyperactive are more than 35 in a minute. When assessing stool, you need to note the color, the odor, the consistency, shape, and amount. Utilize that Bristol chart that we discussed earlier. Perineal and anal skin assessments are necessary. You need to check for hemorrhoids, bleeding, fissures, redness, as well as excoriation. And also, you need to provide interventions and education as appropriate to the nursing diagnosis. Checkpoint. What are good recommendations a nurse can give to a patient to promote regular defecation? These would include encouragement of fluid intake up to 2 liters per day, a high fiber diet such as beans, again, a high fiber diet would be beans, sitting upright on the toilet with knees higher than the hips, and exercising 3 to 5 times per week. Bed rest is not a way to promote regular defecation. Please review previous slides to see other good recommendations. Please review the process of bowel elimination on your own, as this is anatomy and physiology review.